So in this video, we're going to look at MRI of the epilepsy patient, why you should do it, what you think you're going to get out of it, managing clients' expectations, and also what protocol you should use. I'm going to talk you through the Veterinary Epilepsy Task Force recommendation for a protocol and why that will make more use of the MRI imaging for your patient. So this is the second in a series of 3 lectures on MRI of the epilepsy patient, and in this lecture we're going to talk about an epilepsy-specific MRI protocol and why I recommend that this is done. So our aims of MRI for epilepsy and other paroxysmal events is to be confident that the structural problems are identified, to identify lesions that cause seizures, including those diseases that may be managed without anti-epilepsy drugs. So, for example, tumours, or diseases with a poor prognosis. This was a dog that was presented with an infarct to the temporal lobe. And he presented in status epilepticus. I must admit, at the time of the imaging, it was a little unclear whether it's an infarct or it was a tumour. His seizures were quite difficult to control, and because of where it was, there was a very high chance that he would be left with epilepsy, and the owner decided to euthanize him at that point. They very kindly consented to this post-mortem examination, mainly so that we can find out more and have better understanding. We want to be able to identify lesions caused by seizures, so postictal changes and cortical atrophy, and we may want to provide data to advance research. So we may want to contribute cases to retrospective or, more importantly, prospective treatment trials, for example, trying new drugs that might give a better quality of life. We may want to provide data for investigation of pathogenesis of epilepsy. And if we're going to do that, then we need to have a consistent protocol. And in the last epilepsy lecture, I talked about the tier 1 to 3 level of confidence. And it's likely that any dogs that would be included in prospective trials would have to have a tier 2 level of confidence. And that is to say, to have an MRI scan and it to be an appropriate quality, which means an epilepsy protocol. So what lesions may we see in MRI of epilepsy? So in the case of idiopathic, breed-related or other idiopathic epilepsies, the brain will be structurally normal. We may see malformations. This was a dog that I introduced in the last lecture, an 8-month pug with actually a 24-hour history of repeated seizures. He also didn't have a normal neurological exam in that he had a tendency for a right-sided head tilt, a kind of cervical dystonia, and circling to the right, which is a forebrain type of circling, especially when he was excited, since he was about 2 months old. And he has corpus callosal hyperplasia, so this area of the corpus callosum, which is a big white matter tract that connects the 2 hemispheres and allows information to go from one side to the other. This is missing. And you can just see it here. There's a bit of white matter going down there, but no connection going across. And when that happens, white matter tends to go off in all directions and form little bits of circuits. So we can see here that it's not entirely symmetrical through this region. It's not got the same folds as we on one side with the other. And when you're comparing MRI scans, it's important to look at the symmetry going from side to side. And certainly this is not symmetrical, so that it looks like there's some cortical dysplasia going on up in this region. And even in this region, the white matter doesn't look the same as in this region. So management of this pug might be quite different and have a different prognosis to your dog with a structurally normal. We may be looking for metabolic disease, although the best test for that would be an organic acid urinalysis. We're certainly looking for acquired lesions such as neoplasia, brain tumours, inflammatory or infectious causes, maybe trauma, and vascular disease such as hemorrhagic and ischemic infarcts. And if they're there, we want to look for lesions caused by seizures, so postictal changes and cortical atrophy. And this is going to be the subject of the third lecture in this series. So I want to talk to you about an epilepsy-specific protocol, and this is the publication. It's open access, and I would compel you to read it, especially if you're a neurology resident, in which case you really need to read it for your board exams. So what are the principles of these protocols? Well, first of all, the slices should be as thin as possible, as thin as your signal to noise ratio allows, and it should be in at least 2 orientations, and in fact really should be 3. And the sequences should be optimal for the detection of edema or hyperintensity on T2 weighted images. They should be optimal for the detection of subtle structural changes, not just an MRI scan for a brain tumor. And you should be able to detect hemosiderin or calcification as well, ideally. So here's an example of where slice thickness can matter. So these are 1 millimeter slices, T1 weighted, and they're a 3D image, which I'll talk about later, which can be quite useful because you can reformat them in different directions, but only taking the imaging once. So rather than taking 3 separate scans to get 3 different directions, you can get these all at once. Now imagine how small a 3-month-old Maltese puppy is that presented with seizures. So this is a really challenging MRI scan to make. You can see the orientation here, and you can see how important it is to compare one side to the other. And again, in this imaging, we can see that the grey matter, which is light grey coming through here, the folding through here, is not represented here and here. And this is probably an area of cortical dysplasia in this puppy. We don't know because it did not have a post-mortem, rather fortunately, because it was successfully managed. There's a question whether to give paramagnetic contrast, such as gadolinium. It's actually not routine in human epilepsy. I mean, they will always not choose to place an IV catheter and give gadolinium if they don't have to in humans, mainly because it requires another level of technical ability. So somebody needs to be there to actually place the catheter, and it's not without risk, especially in a long-lived animal. Such as a human. It can potentially accumulate in the kidney if you have reduced kidney function. And the reason, most importantly, because they'll certainly give gadolinium if they suspect you to have a tumour, is that there's little advantage if you're investigating idiopathic or, important in humans, temporal lobe epilepsy. And so it's reserved for if there's concern if there's a tumour, a vascular malformation, or inflammatory or infectious disease. Or if those are suspected on the basis of non-contrast studies. And it should also be said in humans, as opposed to dogs, you will get called back for a contrast study if somebody, the radiologist who's interpreting the study, will then require it. And so it's much easier to call back a human than it is to call back a dog and or a cat and re-anesthetize them. So many vets offering MRI will play a kind of defensive medicine game and give the contrast anyway, rather than being have the problem of having to have the animal come back again if it was required, or having somebody say, oh, you should have given contrast. But I would say that the contrast is not an excuse for getting a poor quality MRI scan. It's not going to detect those subtle white matter or grey matter problems that I've showed you in the previous images. So here are the epilepsy protocols. This is for a low field machine, which means Tesla less than 1 T. And the difference with these scanners is they get poorer quality T2 weighted and flare. The best anatomical images are going to be from the T1 weighted images, and so that we need to have our 3 orientations in the T1 weighted, sagittal, dorsal and transverse. We do need to get T2 weighted because these are the best images for detecting edema. and flare in particular because it's able to suppress the signal coming from the cerebral spinal fluid and help confirm lesions or detect subtle lesions. But as I said before, these are extremely compromised in some low field scanner. 4mm slice thickness. If you can get less, fantastic, but you shouldn't be going more than that. And you may be giving paramagnetic contrast. I would say it's probably desirable on a low field scanner just because less quality scan. And this means you're doing 6 to 10 sequences. So actually, to do a good job, you're not just getting 4 sequences, as I've seen some people provide. If it's a high field scanner, so more than 1.1 Tesla, usually more 1.5 Tesla or more, then T2 weighted are your anatomical images, your ones for getting the best anatomy. So we need to have 3 sequences in here, and also at least 2 sequences in flare. I choose a dorsal and a transverse. And T1 weighted, because these are so good in these images, then I will cut down my sequences by just having a 3D technique at 1mm isotropic voxel size. That's actually giving me 1mm slices essentially, and it can be reorientated. And then I will give my post-magnetic contrast with that as well if I desire it. And again, that means I can MPR it and get it in different directions if necessary. And I will also include a hemosiderin calcification sensitive image, such as a gradient echo, and that's usually transverse. And I just give you an example of this. So this is an aged poodle that was presented after a paroxysmal event. And we see a small blip of something here. What is this? Well, it's difficult to tell. It's the same signal as the blood in the blood vessel, but is it blood? A gradient echo can tell us. Yes, the gradient echo, this lights up like a lighthouse or a beacon. This is because this is old hemorrhage and the iron has been released, and this results in this big void on these gradient echo images. And in this particular dog, this was the lesion that I spotted, but she actually had many microhemorrhages throughout the brain, which I hadn't actually realized because they were so small. This is possibly one small one here as well. And so this was not necessarily the cause of the seizures, but showed that she had some ongoing vascular pathology and did affect how we managed her. Now, you would have noticed here that I'm saying to identify hippocampus perpendicular to long ampulus of the hippocampus and parallel to the hippocampus. And you may be wondering about that. And that is the different thing about the epilepsy protocol, is that the sequences are orientated to the hippocampus. And you may be thinking, I'm not too sure if I can find the hippocampus. Well, you can. It's very easy. So basically you get a parasagittal image like this one, where you can just see the ventricle going down there, and the hippocampus is exactly alongside going up here. So you orientate your images like that. So going along there, and that is going to be our transverse images, and this is our perpendicular images. And this is what it looks like. So these are some of the transverse images, and these are some of the dorsal images. And the advantage is that you get this nice sequence through the temporal lobe. This is the mesial temporal lobe, and this is the lateral temporal lobe. Now, imaging of epilepsy is not all about the hippocampus, but all of the other areas of the brain are nicely represented as well. And we can use this technique on both a low and a high field machines. So this is an example of a low field machine. You need to do it from the T1 weighted because frankly you can often barely see the ventricle in the T2 weighted at this level. But we always do the sagittal image first. Now there is surprisingly, or maybe not surprisingly, a little bit of opposition to doing this, mainly from radiologists. Not neurologists. And they will say, we won't do the epilepsy protocol because the brain MRI is always perpendicular to the hard palate. That is set in stone. Well, I would question why. And have you ever investigated the rationale of the initial MRI protocols? Because I think they are most likely to have been what was the most sensible, repeatable protocol at that time. It certainly doesn't correspond to the images in anatomy books. And it is important to have a repeatable protocol. But I would argue that just because you've always done something one way doesn't mean that it should never change or be challenged. And these images are good for looking at anatomy, and I'll show you some more examples later. And also, I find it less confusing to find certain anatomical features, probably because the MRI atlases are available now, especially online, but our original anatomy books, they don't correspond with the anatomy at all. So this is an example of a epileptic golden retriever. It's having an MRI scan. So we find the hard palate here, and then we line up our slices there. So this is the traditional orientation to the hard palate. Obviously, it depends a little bit on the dog's skull morphology, because some dogs have quite curved hard palates, makes it a little bit more challenging. And then, of course, we put the other slices in perpendicular. But if this dog was having a post-mortem, brain out here for a post-mortem, then it's orientated, it's tipped. Because when you make the slices for a post-mortem, you're not doing it at this angle. And so the slices for a post-mortem that form the basis of the anatomy images and all of our anatomy books are actually that way, round, slightly different angles. So it can be sometimes quite difficult to work out. So making the argument that we understand the anatomy better isn't a great one, really. The other argument is that you don't want to compromise your ability to visualize the rest of the brain. Well, I would challenge you to try it. Because when we were developing this sequence, we did try it. And what I noticed was that the cranial nerves came out so much better. So I'm talking about the facial, the vestibular, trigeminal, and other nerves for some reason. I think because it's kind of orientated the same way as the brain is orientated. So this is an image that was perpendicular to the hard palate, and this is the same dog with an image of the epilepsy protocol, and we can see the facial and the vestibular nerve going off here so much more clearly than we can do in this dog here. And you may think, well, that's just a coincidence. Well, this is where I would challenge you, because very quickly the epilepsy protocol in our practice became the vestibular and cranial nerve protocol as well, because we just found that we got much nicer images. And you may worry about head conformation. Well, that is also true of doing it with the hard palate. As I said before, images, I have to thank Marjorie Milne, University of Melbourne. But you still get nice images with all of the head types. I would say that sometimes the brachycephalic can look a little bit strange right at the front, because the rolling of their brain means that the slices actually become coronal, but that's just their individuality. And of course, epilepsy is not all about the hippocampus. So when we're doing an epilepsy protocol, then we also need to make sure that we're looking at other areas of the brain. And this is a chihuahua that was presented with seizures, but actually had inflammatory disease. And we can see the contrast uptake here and the edema here in the flare image, which is highlighting that this dog had inflammatory disease. So when you're making your images, you really want to and assessing them, you really want to make sure that you look at all areas to do with epilepsy. So the occipital lobe, parietal lobe, frontal lobe, olfactory bulbs, piriform cortex, and the temporal lobe. We also need to look at the thalamus, because that is has a participation in spike and wave discharges. The cerebellum, there is some argument that seizures can come of cerebellar origin, but more importantly is that you can see this atrophied in some epileptic patients with refractory epilepsy. And the brainstem is also important for some syndromes such as myoclonus or audiogenic reflex epilepsy. And you can also see it atrophied in some cases with refractory epilepsy. So your take-home message here is that your MRI should be more than just ruling out a brain tumor. You need to be making a diagnosis of idiopathic versus structural epilepsy, and therefore you need to use protocols that optimize the anatomy. So 3 slices and thin slices and 3 orientations, the presence of edema and the presence of blood. And then you need to use your initial images to decide for gadolinium contrast and other testing such as CSF analysis. And in the third lecture of this series, we're going to be talking about MRI of epileptic patients and whether the changes you can see are post-ictal or pathology. Thank you very much.